everyone, we're going to get started. If anyone is out in the hallways or your friends, go grab them so we can get the second half started. So I am absolutely delighted to get to present Dr. Cornelia Trimble, who's a professor of gynecology, obstetrics, oncology, and pathology. So she actually did two separate residencies here, and she's actually been a luminary in women's health, specifically in developing some of the preventative as well as the therapeutic vaccines for cervical cancer. And actually last night over dinner, we were chatting how she's successfully putting herself out of business. So if Dr. Trimble can come up, thank you.
Good afternoon, and thank you in advance for your attention. And of course, for staying awake right after lunch. Okay. As Dr. Olino alluded to, where I'm coming from is that I'm both a gynecologic pathologist as well as an OBGYN. And along the way, I seem to have backed up into immunotherapies. And I focus on pre-malignant disease because early on, it occurred to me that this patient population was going to be an informative one. It's a great time to be in tumor immunology. We're actually making progress. What we're doing is not anecdotal anymore. And here's Jim Allison, who's making us all feel as if we're a part of it. He's really been quite gracious about it. It's huge fun. Alrighty. 20% of human cancers are caused by specific infections with a specific known pathogen. So that raises the possibility of being able to either prevent disease or treat it by focusing a person's immune response on the pathogen. In the case of HPV disease, we have known tumor-specific antigenic targets. The driver genes, if you will, are viral, non-self. These, both of these oncoproteins are required functionally, in a functionally obligate manner, for the initiation and persistence of disease. And we know, anecdotally, that HPV-specific T-cell responses indeed can eliminate some HPV malignancies. After that, we have the same to-do list as everybody else. Okay, we have to figure out a tumor-specific T-cell response. Okay, then the T-cells have to know where to go. Oh, and then they have to be able to function when they get there. And the kicker for HPV disease is all HPV malignancies occur or arise in non-sterile barrier epithelia. So you know that the rules of immune homeostasis are going to be really different in each site. I put this slide together so we can all start on the same page. All squamous cancers arise from an untreated high-grade lesion. This is what a normal cervix looks like in 3 different ways. Okay. This is a cytology specimen. This is a low-power H&E, and this is what it looks like grossly. In the setting of a persistent HPV infection, you get SYN3. And from 40,000 feet, you can see that in these cells as compared to those, the nuclei are bigger, right? Blue is bad. So these nuclei take up most of the cell, as opposed to in normal cells where the nucleus is just an itty-bitty pinprick. This is what a histology of a high-powered, high-grade lesion looks like. And you can see it looks really disorganized and ticked off compared to that. And when we diagnose a high-grade lesion, this is not rocket science, actually. We put a dilute vinegar solution on the cervix, and because these cells with hardly any cytoplasm are going to dehydrate much faster than these, the lesion turns opaque when we look at it with a green filter. Very low tech. And in addition, I'll show you more of this later, so we're looking for this really sharply demarcated aceto-white area. We look for a very pathognomonic pattern of neovasculature called mosaicism. In the setting of a persistent SYN3, I should not be able to show you this last column in this day and age. This is what an invasive cancer looks like. Here are ugly cells with what we used to call a tumor diathesis. This is a low power mag of what the cancer looks like invading. And here's what it looks like when you just look at it. And actually, this is the only slide the medical students ever remember, because I tell them it looks like a cheese pizza. Now then, having said that, pre-invasive cervical HPV disease is really incredibly indolent. We think that immune-competent people, the transition from SIN3 to invasive cancer occurs over the time frame of 10 to 15 years. Of course, we don't know that, but retrospective studies suggest that. And the relevant biological effect in SIN3, similar to other virally induced malignancies, is that the HPV genome has integrated into the host genome. And after that, these two oncoproteins I told you about, E6 and E7, they're expressed constitutively, both in pre-invasive as well as cancer. So when I started on the faculty, I had no idea what I was going to do. So I went into hunter-gatherer mode, since that's where I was on the food chain, and I observed. I had an observational protocol in which I watched patients who had a biopsy-proven high-grade lesion, and I watched them for 15 weeks before doing their resection. That is totally within the standard of care. It's, in fact, the average amount of time it takes to work up a patient at Hopkins. And along the way, because I'm type A, we did an interval colposcopy, even though the likelihood of progression was nil. And at week 15, we did a surgical resection and then had a post-op. Hundreds of women actually participated in this study, and we're very, very grateful to them because we learned some very useful things. First of all, we compare the diagnostic biopsy to the week 15 tissue resection. 20% of these things were gone at week 15. So how does that happen? Well, along the way, we have all of these different kinds of specimens, as you can see here. So we can compare tissue microenvironments or what have you in the FFPE sections from week 0 and week 15. We have peripheral blood. So in these patients and in subsequent patients enrolled in interventional trials with roughly the same schedule, we can look at HPV-specific immune responses. In the serum, which we also have longitudinally, we can look for endosomes and cell-free DNA. On the frozen tissue, which I also get when I do the resection, which I can do because I'm the surgeon, and have worked things out with our SurgPath people. We can do, as you know, a lot of things with fresh frozen tissue compared to FFPE. And because we also already know what's happening in the frozen section, if and only if the pathologist has no suspicion of invasion, we keep the bank block, and we also take a sliver of fresh tissue from immediately adjacent. We got these brushes along the way. I wasn't absolutely sure what we would do with them. We can do now HPV genotyping, but we also can quantitate the microbiota and the virome and the fungome because, this is not a sterile environment. What did we learn? Okay, no lesions progressed during the study window. In some patients, endogenous mechanisms could eliminate incipient cancers. Okay, light bulb moment. These incipient cancers were a great model, if you will, to learn how organ site-specific characteristics enhanced malignant transformation from the pre-invasive state and permitted that to persist. At this point, Drew Mark Pardall marched into my office. This is my only mouse slide, and said, "You want to do HPV vaccines?" I said, "Yeah, okay." Seemed like a doable problem, except like Drew, the only thing I remembered from immunology was that an antibody looked like a Y. So Drew and T.C. Wu had made this DNA vaccine, which housed a mutated HPV-16 sequence for E7. It was mutated in 2 sites so as to abrogate function. However, the configuration was similar enough to wild type that T cells that were activated by this vaccine also recognized wild type. And these are mice that got vaccinated, and these are mice who didn't. In the Black 6 model, this vaccine was preventative as well as therapeutic. This is my first clinical trial. I basically did the mouse experiment, and I gave successively higher doses of the DNA vaccine. This is one of those 1 slide, 3 years of work slides. So anyway, the problem was nothing happened. Here I have depicted ELISpot responses to E7. These are in my observational patients at week 0, week 15. So you know exactly what's going on in the tissue. And these were E7 responses to E7 in non-regressors. Okay, so you don't need a statistician to tell you they're the same. Here were the immune responses that we saw in the vaccinated patients. And they overlap. So the vaccine didn't make detectable immune responses, and the rate of histologic regression was exactly the same as it was in my observational cohort. Well, this is what we learned from that study and others. Peripheral blood immune responses to driver oncoproteins, we just couldn't find them in the peripheral blood. Well, maybe it was a function of where we were giving the vaccine. So we did another study testing intradermal, intralesional, yes, we injected the cervix, and intramuscular administration of another therapeutic vaccine. And again, nothing happened. So these are immune responses to E7 in patients who got needle-free powder mediated intradermal vaccination. Here's in the cervix, and here's IM. The red dots are regressors, and you can see that this is a real bummer. And the rate of regression, again, is the same as in my unvaccinated group. Lest you think these cells are dead, this is the positive control. Okay, what was the lesson there? You need to find a vaccine strategy that's immunogenic in people. At that point, I decided to put on my pathology hat. And you can see right here, you don't need to be a pathologist to see where the party is. This is SYN3, and this is adjacent, normal. All those black polka dots are immune cells. So they all came to the right place. The problem is this dotted line is the basement membrane of the epithelial part of the lesion. And the problem is that all of the T cells are on one side of that dotted line, and the lesion's on the other side. So these guys did search and forgot to do destroy. I mean, they came there and they're all sitting there singing Kumbaya. So why was that? Now then, one method of immune invasion that we see pretty commonly with human solid tumors is the neovasculature down-regulates expression of adhesion molecules. And so we wondered if that might be the case even in pre-invasive disease. After all, we looked for a very specific pattern of neovasculature. Now then, here's the lesion. The first order of business was to figure out what homing integrins were expressed on cervical T cells. I thought they were going to be expressing skin homing integrins because it's squamous epithelium, but none of the T cells in either normal cervix or in SYN3, as you can see, express CLA-CCR4. In the first of many bubblegum moments, the negative control looked like this. Virtually all of the cervical T cells expressed alpha-4 beta-7, both in normal tissue as well as in SYN3. So what's the next thing you do? You go look for expression of the ligand, which is MADCAM. Here's a lesion that allowed CD8 cells into it, serial section. This is expression of MADCAM. And in contrast, here's a lesion that kept them out, and this is the expression of MADCAM. We had to quantitate this, you couldn't just say, right? In any case, we developed pattern recognition software before there was such a thing. And you can see that the expression of CD8, the intensity of CD8 correlated pretty directly with the expression of MADCAM. We segregated into normal epithelium and stroma, and then CIN epithelium and stroma. The tightest correlation was in CIN epithelium, where the correlation was actually 0.88. What did that tell us? If we made a therapeutic response, probably we should think about ways to activate the vascular endothelium as well. And it's good to be able to try more than one thing in a human trial because they take so long to do. And I did this work with 3 characters you may know: Rachel Clark at Harvard, Russell Yang, who's our gynecologic pathologist at Hopkins, and Achim Jungbuth, who's at Memorial. Now then, we actually found a vaccine that made an immune response in humans. It's housed in a recombinant vaccinia vector. And for this next trial, we tested a heterologous prime boost using the DNA prime and then the vaccinia boost. Now then, if the DNA was actually priming a response, we would have expected to see a bigger delta in the response to E7 compared to the response to E6. And away we go. These are the first 3 treatment groups. They all got the same same dose of DNA, and then they got successively higher doses of the recombinant vaccinia. And after the first half of patients, these are in no imiquimod, no alteration, vaccine alone patients, we did see immune responses that were measurable without extensive ex vivo tinkering. That's a really hard step, actually. But we had a runner on base. Now then, we wanted to know, of course, whether tinkering with the microenvironment directly could improve the efficacy of therapeutic vaccination. So simultaneously, we were enrolling patients in a cohort that got just imiquimod alone on the cervix. Imiquimod, as you may know, is a topical TLR7/8 agonist, and we use it all the time externally. We use it to treat warts. We use it to treat small basal cell carcinomas and small AKs, actinic keratoses. We have a lot of experience. I don't know if any of you have ever used it, but it scares up a really ferocious innate response wherever you put it. Now then, all of these patients had HPV-16 associated disease. It turns out that HPV-16 is associated with about 60% of high-grade lesions. So what does that mean? That means 40% are associated with other genotypes. And I had all these patients crying in my office. And because the imiquimod is virus agnostic, if you will, I opened up another treatment group for people who had high grades that were caused by HPV genotypes other than 16, and the short version is the rate of regression in this group was so high that I've had to double the size of that cohort. Now then, the last group got both the highest dose of vaccination as well as imiquimod applied directly to the cervix. We saw something so striking in these vaccinated patients that we published these results halfway through the trial, actually. So what I'm going to show you is data from these patients who got only vaccination, no imiquimod. And I've put on the top right corner the expected rate of spontaneous regression, just in case you forgot it. One big question in the field was, can peripheral vaccination make an immune response that goes where it's supposed to? And we think so. I'm going to show you subject-matched tissue specimens from before and after vaccination. Here's one patient's lesion before vaccination. Here's after. Here's Tibet before. so they're killers. This is a slide, this next set just made my hair stand on end. For some reason, I did Ki-67, which, as you know, is a proliferation marker. The high-grade lesion itself is a nice internal control because it's proliferating. Now then, here's the same patient before, and here she is after. The only reason that a T cell, or at least the top 5 reasons that a T cell starts proliferating, is if it's been activated by its cognate antigen. Now then, not only were there T cells there, they organized into tertiary lymphoid structures that localized specifically to residual dysplasia, if there was any. So those of you who are still awake and maybe thinking, what the hell is she talking about? Excuse me. That's normal. Well, what this is actually, that thing in the middle that looks like a germinal center, that's the tip of a gland. The rest of the gland is not in the plane of section. Looks like a germinal center. Now then, for those of you who are not pathologists, can you appreciate that this white blob looks kind of different from that white blob? Right? This one's not as blue, if you want to get really... the reason it looks interesting is because that's the SYN3 at the tip of the gland, and that's the germinal center. Now then, what pathologists do is we sit in the dark and we look at slides and we put them in piles. And then we look at them again, put them in different piles. It's like sorting baseball cards. So there's no way I could look at 12 of these things and not put together the same story in my head. It turned out that the frequencies of clonally expanded V betas was the frequencies, the T cells in the tissue were clonally expanded compared to blood from the same time point. This is within subject. We did this with adaptive. This was really brute force. These are the top 25 most frequent TCRs or V betas in the tissue, and the same in the blood in a vaccinated patient. And this is what they look like in an unvaccinated patient. Overlapping HLAs, HPV 16. Well, I didn't really know what to do with that. So I compared V betas in patients who had been vaccinated and had overlapping HLA. And here's tissue TCRs in 2 of those patients. I don't know what that means. There's 55 and they drop out. It's so clean. Some in the blood as well. But in contrast, when we looked at vaccinated patients who'd been vaccinated patients and unvaccinated patients who had overlapping HLAs, there's nothing there. None of this is conclusive if it's all indirect, but overall it did suggest that the T cells in the tissue were there by a process of selection and not by leakage. They had a functional phenotype. So there I go sitting in the dark again, did laser capture microdissection of the same cases and looked at the stroma subjacent immediately to residual CIN. And we did an immunology plate. This is in the paper in the supplementary section. But we had a whole panel, a 96-well panel of immune-related genes. This is normal. This is unvaccinated SYN3. And this is the vaccinated. So you can see some differences that are starting to percolate out. Not only was it in the stroma, but we also actually saw it in the epithelial compartment. And again, it had a Th1 signature. So these are all kind of walk like a duck and quack like a duck so far. Not only were there TLS, tertiary lymphoid structures in the vaccinated lesions, let me show you some of the difference again. Here's a patient before. Yeah, she showed me this before. Okay, so here's an HAV of her before vaccination. Here's a higher power mag of that area right there. Quiet. This is what Greg was talking about. It's cold. Now then, after vaccination, her cervix looked like World War III. And it's really, really hot. These guys are trying to organize. And this, again, is the basement membrane. I want to draw your attention to something you can see from low power. This is her residual disease. I think it's maybe 30 cells across. But technically, she didn't respond. Let me show you what that looks like in higher power. Again, this is the basement membrane. These are those vessels. I mean, they're really hopped up and annoyed. And this is what high endothelial venules look like in a lymph node. The T cells are actually getting in. And I understand there's students in the audience. You see these shrinky cells? These guys? That's what apoptosis looks like. So what did we learn? Okay, these were all important things to know. Peripheral vaccination can, in fact, change the immune context in the target lesion. They know where to go. Using conventional endpoints, these patients would not have been successes. They did have detectable peripheral blood responses. It was not by X-fold. There was no, and also in these patients, technically, their lesions didn't go completely away. So what we realized is that maybe it takes an immune response a little bit longer to do its thing, and we were actually censoring the tissue endpoint at week 15. Afterwards, I amended the protocol design. But for the students, what those shrinky things are doing, God bless the postdoc who did this. This is a scanning EM of a killer T cell. This is actually a cervical cancer cell. And what's going on in those shrinky things is this. Kiss of death. That's what those shrinky things look like. It's kind of, I just wanted to make it real for you. So these insights actually informed the design of subsequent clinical trials in this population. I did a clinical trial with a group called Inovio, testing a DNA vaccine that was given with electroporation. Turns out that the electroporation does make the DNA vaccine immunogenic. We vaccinated CIN3 patients at study week 0, 4. We put the boost a little farther out, and the tissue endpoint, we waited until week 36. Well, we cured nearly half the patients. That's 49 point something % right here. This is vaccinated patients and placebo. Now then, we also wanted to know the frequency of concurrent histologic regression and loss of detectable virus. That happened in most of the vaccinated patients, and you can see not in nearly so much of the placebo patients. Now then, these two columns represent people who had mixed infections that included HPV-16. And this effect was even more striking in the HPV monoinfection lesions. HPV-16 monoinfections are the most difficult ones to clear. And here we have a rate of histologic regression that's over 50%, actually, compared to the placebo group. This is consistent with what we saw in the observational cohort I told you about first. And the rate of concurrent regression as well as viral clearance was spectacular in these 16 monoinfections compared to the placebo group. And the phase 3 is now ongoing. Well, that was a really fast overview of a lot of iterations of basically figuring out reasons for failure. And if the students are out there, that's how I've spent most of my career, so don't be discouraged. This is something completely new and different. I mean, I was a T-cell chauvinist because I was raised by that guy. But then we happened upon this really crazy thing. Artesunate is a Chinese herbal medicine that has been used since 400 AD by my people to treat acute malaria. And the person who figured out how it worked won the Nobel Prize for Medicine in 2015. There are millions of people who are alive because of her. We have given people artesunate or derivatives orally as an intramuscular injection. We run it into them IV, And in kids who are younger than the age of 5 and can't keep food down, we give it to them up their little bums in a suppository. So over 2 million people have been treated with some form of artesunate. And so we know a great deal about the toxicity and the pharmacokinetics. Okay. So it turns out that artesunate is cytotoxic to many human solid tumor cell lines. We don't exactly totally know why. Of course, it was cytotoxic to cervical cancer cell lines, and it turned out it was also cytotoxic in a preclinical dog model. Now, this is Dick Schlegel's group. Here's a canine papillomavirus lesion treated with the active form of artesunate. These are just like case reliefs of all of our pictures. It's gone. Our first clinical trial of artesunate was liberating. We formulated the artesunate into vaginal suppositories with exactly the same formulation as we use for Terazol 7, which is what we use to treat yeast infections. It was the same formulation, same applicator. And these patients with biopsy-confirmed high-grade lesions came in at weeks 0, 2, and 4. And the amazing thing to me about this trial, one of them was, if my patient came in and had a negative pregnancy test, we handed her a box of 5 of these things, and she took it home and did it herself. The first treatment group was a low dose, 50 milligrams. The next treatment group was the full dose we planned to give, 1 cycle. Each cycle is 5 consecutive nights. The third treatment group got the same dose, but 2 cycles. And the third treatment group got 3 cycles. Well, halfway through the trial, it was so clear that this thing was working that we also opened an analogous trial for AIN, which is anal intraepithelial neoplasia. Now, if you ever needed a non-surgical therapy, AIN would be the place to try it out. So we're working out the manuscript. The short version is we cured more than 2/3 of the CIN patients. The phase 2B will, with any luck, open after next Wednesday. That's our 30 days with the FDA. The AIN trial is already open, and I can tell you anecdotally, it's early days, but it's working, and it seems to not require an intact immune system. We think it's mediating cell death directly. Of course, we opened up a trial. This one is now open. We formulated the artesunate as an ointment and are using it to treat VIN, vulvar intraepithelial neoplasia. Even though these all share the same etiologic agent, the biology is very, very different. For example, in VIN, if you resect an intraepithelial lesion, even if you have clean surgical margins, there's a 50% chance that that thing comes back. Maybe all of us have this patient. We see patients who are immune competent by any measure that we can measure, and they have nasty HPV 16 high grade. So they're diagnosed in the cervix, you do a cone. Okay, the high grade comes back, so you do another cone. Comes back, so you do a 3rd cone. At this point, there's no cervix left. So when it comes back, these people will get a radical Wertheim hysterectomy. And my first patient who came to see me because she was out of options, she had even had radiation to her cuff, and there it was back at her apex. So we made a compassionate use protocol just for her. And she had been dealing with this repetitive high grade for 15 years. Well, it's been more than a year now, and she has still no detectable HPV. So we gave it to a second patient, amended the protocol, gave it to a second patient. Her disease has gone away. We never see this. And so at this point, this is very unusual actually, the FDA contacted me and said, look, we don't want to see you every time you feel sorry for a patient. Can you just make a protocol that has a specific N, and we'll just go from there. Okay, that's what's new. What's next? What does a successful immune response look like? We're in a very fortunate position to have a lesion and know the histologic context and know a lot of other things from the same time points. So here's a patient that I've shown you before, and these are ELISpot responses to vaccine antigens 16E67 and 18E67. Now, before vaccination at time 0, this is what her biopsy looked like. That's cold, like an igloo. Now then, at this time point, which is week 15, when we did the conization, this is after all 3 vaccinations, she did this. So we can begin to ask questions now about how these things happen. What's going on in a lesion microenvironment that allows a transition from being cold to being a party here? Are these T cells even HPV specific? It's so tempting to speculate that they might be. I mean, they're clonally expanded, they're getting into the lesion, we see apoptosis, but those are all indirect. And I should say that we're collaborating with Kelly Smith, whom Drew mentioned. We're using her manifest assay to identify HPV-specific T cell receptors in the peripheral blood. And once we've plucked those proteins, we stimulate them with overlapping proteins. Then we look for those TCRs in the tissue. In something that looks like that, what does the TCR repertoire look like? Is it clonally expanded? Are they recognizing something else? Is a successful immune response, is that comprised of a monolithic expansion of one super duper TCR? Or is it more broad and maybe not so super duper? What are the contributions of the cervical vaginal microbiome? We are now on these longitudinal specimens able to characterize, quantitate the microbiome in the cervical cervix at these different time points. Of course, we're also looking for other pathogens since they live there. But is there something about the microbiome? We have a sense that in the cervix, it's backwards from everywhere else. Having less heterogeneity is a good thing in the cervix, whereas if the microbiome broadens out, that's a bad thing, which is really good. I can study the cervix microbiome because I really did not want to study poop. Does vaccination change this microbiome? I listen to these talks and I wonder, always have this chicken-egg question. These are still relatively early days. I forget who it was, 2%, right. 2% of your memory cells are in circulation. The rest of them are tissue-resident memory cells, most of which are resident in non-sterile barrier epithelium. They're each going to have different rules for immune homeostasis, most of which we don't know. But if you think about it, if the rheostat is set a little bit too fast, that's what an autoimmune disorder is. So if you're going on a little bit fast forward in the skin, that's like eczema or psoriasis. In the gut, IBD. In the central nervous system, MS. And why is the immunobiology of HPV cancer so radically different depending on the tissue primary site? By that I mean, if a woman comes in with an HPV cancer, cervical cancer, and it's metastasized to lymph nodes, I have nothing to give her, palliative care. Whereas if somebody comes in with a head and neck HPV cancer, if it's stage 4 involving lymph nodes, we cure 80% of them. What is up with that, right? I think we don't know enough about anal disease, but of course here is an opportunity to look at outcomes between people who are living with well-controlled HIV compared to people who are immune competent. Because it turns out, of course, now people living with HIV are almost reconstituted. Their viral load goes to undetectable, their CD4 count comes up to normal. So these people are living reasonable lives, and they're dying of malignancies caused by viruses. So many questions we can ask. This is a diagram that Laurence Zidvogel published a really long time ago, but as she often is, she's on target. What are the immunomodulatory effects of these conventional cancer treatment modalities? Knowing these will give us a sense of in what sequence to give therapy. And there's some basic kinds, but I use these immune suppressive cells as an example because it's really down to earth. One way that MDSC function is they secrete IDO and arginase into the microenvironment. Now, it turns out there's one enzyme upstream of both of them called phosphodiesterase 5. And if that's blocked, you don't get IDO and arginase downstream. And of course, there's a commercially available blocker that's we administer prescribe for, you could argue, completely non-malignant reasons. Some of you are giggling. Do you know what it is? It's Viagra. So can you imagine doing a clinical trial with a 10-day run-in of Viagra? I mean, you'd accrue in about 2 weeks. And the hope is also that we can use these in an intelligent way. For example, platinum-based therapy intercalates into the DNA, and so you see damage. And so you could envision a sequence that would involve giving sublethal chemoradiation. In the case of HPV cancers, that would consist of carbotaxol and concurrent radiation. And the idea is to create a very immunologically noisy cell death. Now, then, Case Malif has reported that in patients who have been treated that way, the frequency of myeloid-derived cells in their circulation goes way down and stays there for about 2 weeks. And so you could envision giving somebody a boost vaccination before or after, actually, but definitely to put the PD-1 blockade within that 2-week window, a 2-month window. These methods can be applied to the study of any solid tumor. This is the basic outline. Figure out a signature in the target lesion that predicts outcome. We're not doing anything fancy because I don't have anything fancy. So this is multiplex for CD8, CD4, PD1, PD-L1. We have another 4 panel that includes CD68. So you can get quantitative information about the intensity and co-localization of infiltration of different immune cell subsets in different compartments of the tumor, and do it in a quantitative way. Our tissue specimens are really tightly clinically annotated. I mean, we know everything about these patients except for maybe what they had for breakfast. And this is in great contrast to studies which are important, but I've looked at 100 normal, 100 high grade, 100 cancer. Here we can see the evolution in a single patient. And this image analysis, of course, we do in a quantitative way. The computer does it, not me. And we can look for, as I said, the intensity of infiltration of different tumor compartments. We can look at the intensity, spatial relationships, and after that, embark on doing all the omics. So we use the histologic context to guide isolation of immune cells of choice. For example, what's going on in a tumor that doesn't let CD8 T cells in? You want to know what's going on in the stroma, don't you? So you can start looking at these different omics. And one thing you should have lodged in your brains so far today is that these tumors are incredibly heterogeneous. And so the idea of, if you get a piece of tissue the size of a pencil eraser and you think, oh goody, I've got tumor, you know there's a lot going on in that piece of tissue. And you get bazillions of pieces of data from these things. And in my mind, I think of it's kind of throwing a ball of mud at the wall to see what sticks. We can also do things like protein expression, and there are epigenetic changes that we see in the stroma. If you figure out a signature in the tissue that's diagnostic or prognostic or can be used to monitor, the next question is, can we find the signature in the blood? Well, if we can find it in the blood, could we find it in the urine? Now, this happens to be possible. You may be aware that the way we used to follow people who had a slightly elevated PSA was they would have a slightly elevated PSA and you would do something rude to their rear end. Nothing going on. So what do? You bring them back in 6 months and you get a blood. And then it's kind of the same. And you bring them back in 6 months and it's kind of the same. The reason we follow these patients so closely is to catch the one guy whose disease takes off. So my colleague Michael Donovan figured out a signature in the prostates that had taken off and then validated it in 200 or hundreds of prostatectomies. This signature was pretty simple. It was 3 different proteins. So they looked for it in exosomes in the blood, and by gosh, it's in the urine, and that test has now been FDA approved. If you can imagine being able to screen for HPV disease that way, that would be actually a game changer, because outside of the cervix, non-cervical HPV cancers, we have no way yet to screen for them. Okay, I'm going to finish up by leaving you with some words of caution. We've gotten to the point where we think that the tissue, what's going on in the tissue, is the truth. Here are the top 15 most frequent V betas in a patient frozen tissue from her resection. Okay, if you do it the way everybody else does it and does disaggregation and looks for the same V betas, you can see that what you're studying is what survived. It's not necessarily what was actually going on in the tissue. And then just for the sake of comparison, here are the frequencies of those V betas in the blood. It's true in mice, too. Disaggregated tumors. David Mazepust published a paper in which he looked at frequencies in cells. Now then, he estimated the numbers of T cells in 5 different mouse organs, in 2 ways that were completely quantitative. One way, he did serially sectioned organs and then stained for CD3 and then extrapolated to get a sense for how many cells per organ there were. And in another approach, he got whole tumor DNA and figured out the number of cells per organ that way, and they correlated pretty tightly. Okay, here's the kicker. When he did disaggregation and saw what came out, the black bars are what you got when you did it this way, and the gray bars are what came out from the tumor-infiltrating lymphocytes. Basically, if your organ was kind of squishy, the more likely you were to recover about the same number. In the female reproductive tract, that was so not the case, as you can see here. And part of the problem also, this scale is a log scale. So the problems with this approach is that you get really just a fraction of the tissue immune cells. Unless you have another chunk of tissue from the same adjacent to where you did this, you've lost the histologic context, so you don't know what's going on. And of course, physical manipulation activates cells, and it just explodes macrophages. So when a pathologist sees this methodologic approach in a grant application or a paper, we call it grind and find. And really the thing I want to leave you with is that if you're studying immune responses using this approach, you should be aware that you may be asking a very different question from the question you think you're asking. Okay, in DC, people laugh at this. Well, how the heck do you do that? How do you get unmanipulated cells from a specific microenvironment and figure out what they're doing? Because a lot of the single cell sequencing requires that you have viable single cell solutions. That doesn't happen in solid tumors so far. So we developed this approach. We have figured out how to do rapid immunostaining in under 30 minutes on cryosections. And then the postdoc runs downstairs. This is pattern recognition software. I want you to look right there. Keep your eye right there. Did you see how instantaneous that was? We asked the machine to go find everything. This is the lower level of brown. This is the upper level. It's just like thresholding for flow. Go find everything that's at least this big but smaller than that. And so what Leo is doing now is cleaning that up because we didn't threshold it quite right. Conversely, if you think it missed something, you can just circle it on the screen because it's a bamboo screen. And you can see we're getting a spreadsheet here of the absolute area. Okay. What happens? These are Hofbauer cells. These are placental macrophages. These are unmanipulated, specific cell subsets from a known histologic context. And so you can then go on and do omics within the lifetime of a postdoc. I'm going to wrap with this slide. This is a table of the methods that we've developed using human tissue specimens, which are all itty-bitty because, of course, the first priority is to make sure not compromise the ability to make an accurate diagnosis. And these methods are, of course, evolving. We can do more and more with the FFPE. So that's what I got. Thank you for your attention, and I'd be glad to take questions. You all believe me?
Have you started to look at any of, with the viral antigens, the possibility exists that, as with the vaccines, that you could have off-the-shelf products that might work for some patients, or, the idea of using those shared or common antigens across patients. Any ideas related to that? Aside from the vaccine's obviously one approach.
Yeah. I mean, ideally, in terms of vaccine, yeah, but also in terms of TCRs, you could imagine somebody comes in, has an HPV disease, and you get their HLA profiling, and you say, oh, we have a really good T-cell receptor for HLA-A2 and a really good one for so-and-so, and those would be off the shelf.
That was really interesting. I'm wondering about the basement membrane and why it is that the cells kind of sit there. Do you have any thoughts?
Yeah, one reason is because the neovasculature that we look for in these lesions, that has downregulated expression of the adhesion molecules, which is why we scared up an innate response with the Aldera to activate that endothelium. But there are other things going on, without a doubt.
Once they're in the tissue, right? Those cells are in the tissue. So why do they just stop at the basement membrane? They can't degrade it, or?
No, that's a very complicated question. Part of it relates to what Greg talked about this morning. There's not a lot of, they're starved right there on purpose. Of course, the lesions, even at this point, have recruited immune suppressive subsets. So there are many reasons, and I'd be happy to work with anybody on these because, and now that we can actually quantitate the microbiome, most of the studies that I've seen are like counting jelly beans, and it's good to know that this clinical setting is associated with this kind of diversity and this kind of pH. And this clinical setting is associated with what. But now we have the opportunity to quantitate the microbiome and know what's going on in the tissue at the same time. So what is it maybe about the quality of how the microbiome activates a local innate response that contributes to this cold thing, and vice versa?
Of the tertiary lymphoid structure in the responders, it looks great. So have you thought about whether the B cells or T cells in the tertiary lymphoid structure recognize the same type of antigen as that's in the lymph node?
Yeah, that's a legit question, is what are the cells in the tertiary lymphoid structures recognizing? We're working on that right now with Kelly Smith with the manifest technique. So what we do is you can either predict epitopes or use just overlapping peptides that cover E6 and E7, and take the patient's peripheral blood and put one peptide per well, and you can pick out the ones that get activated. And so those are recognizing some piece of the HPV. So we then go and look in the tissue to see if we see those TCRs. It's very difficult to measure function from T cells that you pulled out of a tissue. It's almost if they need something in the tissue to be activated.
More question. So right now there are vaccination against HPV. So for those people are vaccinated with the HPV vaccine, like with IV vaccine, are they the B cell are the B cell repertoire in those patients similar to the patients with this the vaccine you did in the clinical trial?
I don't know because I'm a T cell chauvinist, but I'd be happy to look at B cell responses with you. Thank you.